titled the talk, COVID and the Transformation of Medicine. Thank you for that nice introduction. This is just a little bit about me. I had a Hertz Fellowship starting in 2006. I was doing engineering at Rice, and this is my thesis title, but basically the mechanobiology and tissue engineering of heart valves. I got my MD from Baylor. I did a postdoc at Stanford, and then I did residency and fellowship in adult cardiothoracic surgery at Columbia. I did a fellowship in congenital cardiac at Northwestern, and then I'm an assistant professor at Mayo Clinic. This is what I do every day. So this is I think a 4-day-old. Those are coronary arteries that it's called an arterial switch operation, but the coronary arteries had to be moved to a different vessel. These are about the size of pickups. So I do things that are pretty small. And these are my patients. I love my patients, and I love what I do. And my perspective will be a little different because I'm not an infectious disease doctor or a critical care doctor, but I'll share some of kind of my perspective. This is a great article from the New Yorker that talks about the historical perspective of pandemics. And basically, historically, pandemics have led to dramatic change. For instance, the Black Death killed unfathomable portions of the population. It's estimated between 75 and 200 million died. Half of the city of Bologna, entire cities were wiped out. But it's thought that this was in part what led to the Renaissance. And I'll talk a little bit more about that. So in Italy, in the setting of the Black Death, suddenly labor was very scarce. Wages for artisans went up, workers had a voice. And the Italian poet Petrarch was very disheartened by what was going on, investigated the letters of Cicero, and Petrarch really was motivated to try to restore the glory of the past and wrote about change, which kind of led to some rumblings that then other events could lead on. Technically, the end of the Middle Ages occurred after the fall of Constantinople in 1453, and when libraries were brought to Italy and Europe, but the culture being ready to embrace change in large part had been initiated by Petrarch and some of the elements of the ramifications of the Black Death. So then the Renaissance came, and scholastic medicine, which was basically just referring to these classic texts, was really abandoned, and that led to the revival of medical science, where we actually investigated things in terms of anatomy and physiology and things like that. And this was a great fresco that I enjoyed called The Triumph of Death from that era. What about other pandemics? But a number of other pandemics have all had radical societal ramifications. The specifics of those have varied. So for instance, the plague of Athens in 430 BC led to a period of lawlessness and immorality with loss of faith in democracy. The Spanish flu in part led to women's suffrage, but also the Roaring 20s and vast disparity in wealth. So what about COVID? Well, we know that the new normal is going to be different. We don't know what it will look like. But here are some reflections. This comes again from the New Yorker article with this Dr. Pomada said, pandemic as an accelerator of mental renewal. And I really like this quote by Lawrence Wright, who wrote, like wars and depressions, a pandemic offers an x-ray of society, allowing us to see all the broken places. It was possible that America would do nothing about the fissures exposed by the pandemic, the racial inequities, the poisonous partisanship, the governmental incompetence, the disrespect for science, loss of standing among nations, fraying of community bonds. Then again, when people confront their failures, they have an opportunity to mend them. And I think this is very much true in the practice of medicine, which I'll get into further. So very briefly, again, this is not my specialty, but COVID, the source in humans remains debated. That Hunan seafood market hasn't seemed to pan out in terms of that being the first source. But the virus was first isolated on December 30th from 3 patients in Wuhan, spread as contact and droplet. It's sensitive to most disinfectants and heat, but more stable on some plastic and stainless surfaces. It comes from a family of beta coronaviruses. These are enveloped RNA viruses with a variety of natural roots. In terms of their clinical effect, they affect the lung system, enteric, so GI, liver, and neurologic. The MERS virus is from the same family. Bats are thought to be the most likely the natural hosts, but there appears to be an intermediate host because the bat version can't infect humans. Cell entry is via angiotensin converting enzyme 2, which you guys I'm sure have heard about because it's a medication that we use commonly in cardiovascular disease. And then since the initial patients, the viruses have been isolated, there appears to be two major strands, L and S. There's some evidence that L may be more aggressive and spread more quickly, although that's still being debated. RNA viruses such as these are unstable and will require continued surveillance for changes. This is a diagram showing the bat host, and you can see here SARS and MERS, both from the same family, and then the intermediate host, and then moving to humans. Here is the virus diagrammatic of that. The spectrum of disease is this, as I'm sure you've heard, is quite varied. So about 1% are asymptomatic, 81% mild to moderate disease, 14% critical, severe, 5% critical. And the most recent data that I saw was about a 2% mortality, but 15% if you're over 80 years old. One of the things that is very fascinating is that children can be asymptomatic in up to 16%, and we've certainly seen that in our kids who come to see us. So why is COVID so dangerous? Well, the key is spreading the virus while patients are asymptomatic. Each COVID patient can spread to 2 to 3 people, and that's almost twofold that of the common cold. And they have a longer incubation than the flu. So if you see in that table below, it can be up to 14 days. The mortality is actually lower than SARS and MERS. And then this shows the mortality rate. Again, that 3.4 is older numbers. It's now closer to 2, they believe. And then SARS and MERS with higher mortality. So what about physiologic effects? Well, one of the most important is called ARDS, which you've probably heard the term is acute respiratory distress syndrome. This is something that we're relatively commonly used to seeing. So actually at Columbia, we would have about 10 to 15 patients at a given time in the winter who had just the common flu, whatever the flu version that was going around that year. And they would develop this severe lung injury where they're not able to oxygenate or what's called ventilate or remove CO2. And they require ECMO, which I'm sure you've heard about, for the lungs to recover. So we're used to seeing flu and other, there can be pancreatitis can cause ARDS, a number of things can cause ARDS, but this is one of the ramifications of the COVID virus. The other thing that we've seen that's more unusual is a cytokine storm, so a very robust inflammatory response to the virus, which we don't see in other similar viruses. And then one thing that was very marked when I was talking to my colleagues as they were first getting cases at Columbia is they would put these patients on ECMO, which we're used to managing, and they would develop clots. And this is something that we've learned more about that's unique to COVID, that they have this procoagulable, it's called state, but basically means that they're prone to clotting. So what about cardiac and congenital effects? So thankfully, children and our congenital patients have largely been spared. There is something called Kawasaki disease. Now, this is an autoimmune type disease that we see in children that basically they have an inflammatory response that affects their coronary arteries, and they can actually present with ischemia and heart dysfunction as a result of this. Well, it appears COVID can invoke something similar to Kawasaki's, and again, it's immune mediated. Now, adult cardiac effects, they've named this COVID cardiovascular syndrome. One portion of this is what they're thinking is a form of acute myocarditis. Myocarditis just refers to inflammation and injury to the myocardium or the heart muscle, and that's without ischemia. So the most common cause for heart dysfunction, or one of the most common, is myocardial infarction, or in other words, the heart doesn't get enough oxygenated blood. But in myocarditis, which can be caused for a whole host of reasons, including other viruses, there is injury to the myocardium without ischemia. Other things that we see is heart failure. The two main things with COVID-related heart failure are cytokine-mediated and stress-induced. And then the thromboembolic complications have been Also very evident pulmonary embolus, so clots to the lungs, clot within the heart, which is a huge issue because that goes to the brain, and then stroke. One of the things that's been fascinating is much of the emergency room business at any given hospital is heart attacks. And that those have been down 40 to 80%. It's still a little unclear why this is happening, given that heart attacks are associated with high stress states, and all of our society is in a high stress state. There's thought to be that people are fearing coming to the ED, so they're waiting out these heart attacks, but that part is really unclear. So this is from a Circulation article, and it delineates the heart effects for COVID, and you can see at the far left, acute coronary syndrome. This is heart attack, STEMI, and NSTEMI is different types of heart attacks, where you have coronary vessels that are not allowing enough flow to the heart. This is the myocarditis type picture where you have heart injury without ischemia, and so it can be from myocarditis, cytokine issues, and stress cardiomyopathy. There are a number of other things that we see less commonly: arrhythmias, this heart failure, you can get fluid around the heart, and then this shows, this is the pulmonary artery, the white, and then this is a big clot in the pulmonary artery. So this is the clot, one of the clotting issues that we see in COVID. And then this summarizes how, so myocardial injury is usually characterized by troponin, which is leaked out from the myocytes when they're injured. And so we do see that in COVID patients, and there's a number of related things that can cause that. So the medical impact of COVID, you could go many directions with this, but I kind of delineated it in a few key areas. One would be depletion of resources, and this has been really drastic and affected every specialty. So it includes equipment. I'm sure everybody has heard about that, including the PPE, personnel, because of the shortages and trying to decrease exposure and quarantine, blood products, and then of course ICU, ventilators, and OR spaces. There's also been a vast reallocation of resources. So many of the OR nurses were sent to the ICU, OR vents were used for the ICU, different trainees were sent to either the ED or the ICU. The resources were reallocated for the need of a given hospital. Now there are some specialty specific impacts. So obviously the emergency room inundated with cases, and how do you deal with something that's spread easily in an emergency room, which is not usually set up to handle something like a contact or droplet infection. ICUs were overwhelmed. Cancer care was challenging because, for instance, lung cancer, we know anybody with a lung or pulmonary issue makes them at higher risk for COVID complications, but also you don't want the cancer growing. So they did go ahead with many of the cancer surgeries, knowing that those patients are at increased risk. Outpatient care has been limited and virtual. That has picked up a bit since the real height of it, and then certain specialties have basically been on hold. As far as cardiothoracic surgeons, especially the adult group, they've been needed for adult COVID positive ECMO patients. And then the third main medical impact, I would say, is this attempt to limit exposure. So basically everyone is off site except for those who have tasks that require you to be on site for patient care, which also has been a huge IT challenge. Patient care has been really changed dramatically. So now we're on rotational schedules to try to block exposure, decreasing the team size. We realize that we have a lot more people taking care of patients than maybe are really necessary, and limiting trainees and their contact. So this is, as I said, I trained in New York, and I was there for 6 years, and many of my mentors are still there and colleagues. So hearing their stories has been difficult, but the impact was early, drastic, and rapid. These are just a few anecdotes, but one of the young anesthesia attendings, who must have been in his 50s, was on the vent for weeks, otherwise healthy. One of the young surgeons, who was one of my attendings, was COVID positive, was hospitalized, but then he has a young family, so he was trying to find an apartment to live apart from his family to protect them. A very famous surgeon, who's not a cardiac surgeon, was on ECMO for weeks. one of the nurses there who actually was a cardiac patient, relatively young, who has underlying heart and lung issues, called me because she was being put on a COVID floor. And you know, I talked to her. I said, you need to tell your supervisor that you're at high risk and you should be trying to. She was an OR nurse, so she wasn't even an ICU or a floor nurse. But apparently that just wasn't able to be changed. So she was put in a high risk situation. The lack of PPE was really hard to hear about. All our cardiac ORs in New York were converted to the ICU, except maybe one, I think, adult cardiac and one congenital. One of my main mentors, who's a congenital surgeon there, talked about how difficult it was to decide between emergent cases. So in other words, these are babies or children who need to go in the next day or two or they could die. And he would have to decide between cases. And this was because he lacked his staff because they were being reallocated to other areas. He lacked beds and ventilators. And that's just a very difficult place to be as a surgeon to make those types of decisions. One of our nurses, OR nurses, committed suicide. And then you probably heard one of the ED attendings where I had worked also committed suicide. Codes were run differently. So when a patient arrested, it used to be in the ICU, there'd be about 5 people and they would all have very specific roles. Like one person was in charge of meds, one person was doing compressions and rotating with another person. Anyway, there were about 5 or so people. And during COVID, one nurse would go into the room. They would do compressions for 1 round and give 1 dose of epi, I heard. And then if the patient didn't come back, that was it. And that was because of the shortage of people and because of the exposure concerns. And of course, lifestyle in New York, you're in crowded apartment buildings. They're unable to go outside because you can't be distancing. So this was really hard to hear about. And from this, you may have heard, this is me operating with Dr. Smith. But Dr. Smith is a cardiac surgeon who also is the head of surgery at Columbia. He did Bill Clinton's cabbage and is very established. But he wrote this daily email update that became sort of a national following for many people. And it was a fascinating, went on for about, I think, 6 weeks or so. He had reflections on COVID, healthcare, life and death trials. It's very good reading. And he was named by I think it was Wall Street Journal, the writer of COVID. So I just included one excerpt here and one on the next slide. He says, it may be obvious that writing these updates is a daily struggle to balance terror and reassurance. Today, the steady drumbeat of new cases continues, and it remains possible that our system will be overwhelmed. Repeating the threats represented by a lack of PPE and testing can feel corrosive. In some, the accelerating pace of this contagion so easily overwhelms me that I risk becoming the jaws of doom surfing. But this is a day I'm mostly astonished by the explosion of energy and creativity being applied to the battle. Not knowing when the dawn will come, I open every door, Dickinson. Doors are flying open all over the place. And then this was another excerpt from a different one that I really enjoyed. He says, it would be nice to say that our split ventilator experiment is first in man, but therein hangs an interesting story. In pursuit of increased ventilator capacity during natural disasters, Naiman and Irvin described successful in vitro ventilation of 4 simulated lungs with 1 ventilator. 11 years later, Kevin Menes was in charge of the ER at Sunrise Hospital in Las Vegas when 215 victims of the country music concert mass shooting poured in. Dr. Menes thought of Dr. Naiman's experiments because they had been residents together, and he applied the technique successfully to some of his gunshot wound victims that night. Why do I mention this? The history of healthcare shows that wars are times of rapid acceleration in the art and science of surgery. Surgery takes the lead in many natural disasters, but we depend on others to lead us through plagues and epidemics when it's our turn to fill whatever supportive roles are available and cheer them on. As one hand washes the other, today a technique forged in the crucible of mass trauma is helping our medical colleagues manage COVID-19. Turn, turn, turn. No one of us is smarter than all of us. So what about at Mayo? So it's a huge hospital system with a very small population. Mayo's response was quick and very conservative. We were only allowed to do emergent cases. There were rotations for surgeon and NP PA coverage. There were furloughs that were immediately put in place, and they released all like adjunct services. There was rationing of PPE, screening before work, so I still have to take my temperature. and attire. So it used to be that at Mayo, many of the physicians would come in suits, and you had to, they would give, this is what I was given. So I had one face mask that I was allowed to use. This is not my N95, and then one set of scrubs. Rochester is obviously very different from New York. There's plenty of space. People largely live in houses as opposed to apartment buildings. But as many, I'm sure, have noted in their COVID experience, it has been extremely isolating. So what about the patient experience? So for adult cardiac surgery patients, during the worst of it, they were not allowed to have any visitors. The only exception was end of life. The pediatric patients were allowed one guardian at a time with a limit of 2 people switching on and off, and they also had to have COVID screening. One caveat that was really hard was only one guardian was allowed to wait during the operation, and so they often wouldn't want to wait alone, so they would wait together in the hotel, but then I wouldn't meet with them in person after the surgery to tell them how it went, which was very hard on patients. We were trying to incorporate patient support via FaceTime and Zoom and other mechanisms, but much of the hospital provided support services were not available. So things like social work or chaplain or various things that they try to use to help our patients get through a very stressful time. Now, what about congenital cardiac surgery? Well, there are 2 of us, 2 surgeons. I'm the junior one. There's a very senior surgeon who's my boss. So I basically tried to take all the exposure so that to protect him. He's also the president of the STS, which is the National and International Association for Cardiac Surgery, Adult Cardiac Surgery, Adult Thoracic and Congenital. And he's also president of the Congenital Heart Surgeon Society. So it was most important that he be protected. We had a case on March 2nd where it was a little kid who crashed, and we were concerned that this could be COVID. Now, this was very early, and even New York wasn't that affected, but it really forced us at Mayo to figure out how we would handle COVID. And I think that was a very good thing, because we didn't have negative pressure rooms in our cardiac unit. We didn't have a rapid way to get a COVID test. We didn't have enough PPE for that. We hadn't figured out how to, all these like logistical things. As far as the ensuing next couple months, we actually had a number of urgent cases. So I was operating 3 to 5 times a week. I normally operate, well, every day, not as much on the weekends. And we had a busy ICU. In many ways, this was very good for me because it gave me a little bit of a sense of normalcy. You know, I would get up and round at 6:30 in the morning. I would be there all day. So I still had sort of this daily routine, which was for me very helpful. We had given really very low impact on children, even children with heart and lung issues. We actually were not called for any non-cardiac ECMO patients or ECMOs for our patients. The biggest challenge for us, and this has been true across the country for congenital cardiac, is what do we do about cases? And we don't have nearly the limited resources, but we were instructed only to do urgent emergent cases. We had limited staff. And then how are we going to put potentially patients at risk by bringing them in during this COVID time? Mayo itself was a ghost town. It's a massive institution, and really I would see my patients. I might see one other physician, and the halls and the outpatient areas were just absolutely empty. So it was a very eerie feeling. So my boss, as I said, is very established and high up in our field, and so one great opportunity for that is to be involved in some national and international committees and papers and things like that. And one of the things that we realized very quickly is we have no guidelines or any sort of advice on how to prioritize congenital or kids who need heart surgery. So we know when, if you had open ORs and you had your choice and you didn't have COVID, we know when certain lesions need to be fixed. And a lot of kids can't wait because of their physiology, but in the setting of very limited resources, how do you pick between different patients? And so this was a paper that I wrote with Dr. Durrani and other leaders of the different organizations, and it concentrates on prioritization of cases one of the hardest things was we didn't know how long, if you're going to delay your surgery, we didn't know how long we were going to be delaying it. We didn't know if it was going to get worse. We didn't know if we could do it in a month or we would be waiting 6 months. And that, some of these kids can't wait 6 months. It emphasizes regional collaboration because, like many centers, most congenital centers have, I think it's a median of 2 surgeons. So, and we're often together. So if both have to be quarantined, you lost your entire congenital cardiac surgery specialty at your institution. So we have a great relationship with Minneapolis. So that's who we collaborate with. We talked about how to limit exposure, and our workforce. So for instance, our PAs and NPs are very specialized. You can't just replace them with other types of NPs because our patients are pretty specific. So we really had to be careful about making sure that they're also available. We talked about COVID screening and the role of ECMO for non-cardiac pediatric patients. So then how did this change? Well, Mayo took a huge financial hit. There was many of our patients come from nationally and internationally, and they were not traveling. And of course, all the elective procedures and outpatient clinics were closed. So there was this huge financial hit, and then there was all of a sudden pressure to rapidly and yet safely, so we were concerned about possible resurgence, ramp up cases. So it was kind of this weird dichotomy where like you weren't allowed to do any cases except emergencies or urgent cases, and then all of a sudden they wanted us to do lots and lots of cases, but the cardiologists hadn't been seeing patients, which is our referral pattern. The travel for Mayo patients has been challenging. For a while, we weren't accepting patients from high-risk areas such as New York. Patients have been afraid to travel. The screening protocol was done at Mayo for COVID, and some patients traveled and then were delayed because they had indeterminate IgGs and things like that. We did provide coverage for neighboring congenital programs, and then we did have this is one of the hardest part. One of our congenital patients died, and one adult patient died due to delay of their surgery, which is a risk for this heart surgery, and they're scheduled for surgery because they need it. And we also had one adult cardiac patient die. He had come from California, and we think this was early on. We think he was infected, and we just didn't realize it. As far as impact on my practice and the congenital practice, some of the hard things are I was brought on to Mayo to really build up the peds bit practice, and that comes from Fargo and North Dakota and some of the surrounding areas, and I haven't been allowed to go out and do outreach. So it's been a challenging time. This is another article that I wrote with Dr. Durrani and some of the other leaders of the field about reactivation, and that's also been challenging because we don't know what kind of risk we're taking on. And the goal is to, of course, maximize the benefit to the population while minimizing risk. Emphasis on protecting healthcare workers, also using, again, team-based care where you're trying to minimize exposure. We've continued to have to try to select and prioritize cases. There's really no evidence behind this. This is something that is expert opinion. We're preparing for possible resurgences, and then how to manage patients who need surgery who either have symptomatic COVID or if they have a history of COVID. So many of our kids are coming in and they're IgG positive, and you talk to the parents and they've never, or I shouldn't say that, they in the last 4 to 6 months have not even noticed a cold. So it's interesting that the kids really have not been symptomatic for the large part. This is something that I wrote with Dr. Durrani again and another physician, but I think we'll see increasingly, especially talking to the New York, some of my colleagues there, and that's the impact of this on mental, emotional, and psychological health. It has been really, really hard to provide medical care in this setting. And congenital cardiac surgeons are already at high risk for burnout. There's some literature on that. We're in a high risk specialty. We're very perfectionistic. We work really hard. We're on call all the time. And all of a sudden we lost our routine, and we lost what we love to do and what kind of gives us value. Again, that was one of the reasons why me having 3 to 5 cases a week and rounding every day and being at Mayo every day was very, I think, helpful for me. And then in the setting of COVID, of course, not only do you have this professional stress, but then you've got personal stresses related to your family, whether for me it was my parents who I was in a high risk situation. you have the professional stressors. It's been really challenging to kind of feel like you're acting like God and deciding who gets surgery and when and who doesn't. So that's really a hard place to be, and certainly not something that we've ever been in that place before. I'm sure in other third world countries you might be doing things like that, but not in the US. And then unknown future regarding COVID, when it's going to abate and how long you can delay. It's also been very stressful on the entire team. So unlike other settings where, you know, you might be going through a hard time, but those around you can kind of buoy you up, everybody's stressed in different ways. You know, our secretaries are trying to work from home, but they're also doing childcare and trying to teach their kids. So I think there'll be a lot of collateral damage on mental health, and that, based on other pandemics, can last longer than the pandemic itself. So what has COVID uncovered about healthcare? I would say fragility of the infrastructure. This has largely been unapparent to the consumer, but we've been aware of it. So there have been examples where there have been shortage in heparin, which is what we use for every day for going on the heart-lung machine. Saline, which is like water in a hospital, and that's just from lack of diversification. You know, we're getting some of these things from key. So in one case, it was Puerto Rico. So once Puerto Rico had an issue, we lost, you know, supplies. I think it shows the fragility of the healthcare system, being able to respond to regional needs and put our resources there, and then fragility of the public health policy, just not being prepared to handle large-scale public health issues. As far as going forward, how is this going to transform healthcare? I think the biggest thing will be virtual medicine, which we've used some, but not to this extent. Many parts of the in-person physician visit can be virtual, and that includes physical exams. So there are other specialties who have talked about that. But basically, before I do surgery, I don't actually need to see a patient for the vast majority of patients in person. Virtual healthcare has potential to both increase and decrease healthcare disparity, and people have written about that. You know, there is the benefit that people with lower income don't need to fly to Mayo and have that expense, but at the same time, you need the resources to know how to use information, you know, technology, and have internet support and things like that. This is a new learning curve for physicians. We are taught how to see a patient in the clinic and do a history and physical. We don't know how to do a good virtual visit. There's also some challenges for institutions, so licensure and coverage. So I'm technically covered in Minnesota and Illinois, but how do you deal with providing medical advice for a patient who is currently in another state? And then the virtual medicine has been a double-edged sword, because Mayo has increasingly seen patients who are shopping, where they're taking up physician time, but not intending to come to Mayo. Other things related to transformation of healthcare, I think we'll better be able to triage patients. We've really been paring down teams. We had a lot of duplication, I think, of staff. It has really encouraged international and national collaboration. So this is a Zoom meeting. I had another one this morning with, it's called World University, but congenital heart surgeons from every continent who are working on creating webinars to help educate particularly third world countries to provide good congenital cardiac surgery care. But this has been increasingly happening as a result of COVID. And some of it's, you know, been consulting on how they're dealing with COVID in their hospitals. I think private practice cardiac surgery will likely disappear. You just don't have the resources to withstand a huge hit like COVID has had. There'll be increased infrastructure and preparation to public health crises. Medical meetings are going to be largely virtual going forward, which, you know, certainly does have a drawback, but also within our daily life at the hospital, we're increasingly using Zoom and other technologies, whereas we would have been in a conference room. And I think that will be used more going forward, which provides further flexibility if you're not physically able to make it. I know there were some questions about the long-term physiologic effects. I mean, we don't really know. I think the biggest two things would be the immune system has memory and it has long-term effects even when you get over something like a virus. So what that looks like for COVID, we don't know. And then there are likely going to be long-term effects on the lungs and vasculature. So CTEPH is a chronic thromboembolic, it affects the lungs, but that's something that we see in patients who have pro-clotting issues. So that's something that you would see. You would see pulmonary fibrosis, which is like a scarring of the lungs. so there are some long-term potential physiologic effects we don't really know. And then as far as outstanding questions, I would say a few things. Rate of mutation change of this virus. And again, I'm not an infectious disease or virologist, but that'll be something that we don't know. The ability to create an effective vaccine in a rapid, safe manner. There's a lot of concern regarding that. There's a lot of screening of vaccines to make sure that they don't have undue side effects and make sure they're effective. The ability to safely reactivate medical care, which has been a huge issue. So, Texas is now overwhelmed. Many other centers are very overwhelmed. And then the question of immunity. So is a positive IgG enough? And that's not necessarily clear for this virus. So thank you for your time and attention. And I'm happy to take questions if you want, or I'm not sure if that's later.